Hello, my name is Julie Pack, and I'm an associate professor of medicine in the Division of Rheumatology at our Johns Hopkins Myositis Center. I also act as a co-director and director of clinical trials here at our center. I'm very excited to be here to discuss on Rare Disease Day, MDA5-associated dermatomyositis. It's really an honor to be here to discuss this specific disease, but I have to say it's going to be very compact and a very brief story or journey through MDA5 dermatomyositis today. So I just want to give a little bit of background that I'm sure all of you guys know, but if you don't, dermatomyositis affects about 25 to 50,000 per 100,000 in terms of the prevalence. It's a very rare disease. And we know that our patients can have multiple manifestations, including skin disease, as you can see here, with the classic Gotrin's rash or skin rash over the knuckles that can be quite itchy and sometimes painful. And also the heliotrope rash, named after the heliotrope flower, which have purple petals. So it can be almost like a purplish eyeliner, like red discoloration over the eyelids. And it can have associated swelling as well. It can also have rashes on the knees and also the Holster sign, which is on the side of the legs. And of course, dermato meaning skin rash, but also myositis meaning muscle inflammation. You can actually see a lot of muscle inflammation in some of our patients, but the spectrum is quite heterogeneous. And so to highlight this, I have this slide where you can actually have this spectrum of amyopathic dermatomyositis, meaning that you do not have any muscle involvement at all, but you have skin involvement. So this is why the skin is in pink and much bigger involvement. Then you have hypomyopathic dermatomyositis, where you actually be quite strong on exam when the physician is testing you, but then on skin exam, you still have significant rash. But if I did a deeper dive and try to look for muscle involvement with maybe an EMG, which is electromyography and electrical test, or a muscle MRI or muscle enzymes that you can test in the blood, we would see evidence of inflammation. And the classic dermatomyositis is where we have full-blown muscle involvement and full-blown skin involvement. Now, I think the important caveat here is that I'm talking about dermatomyositis as if it's only skin and muscle, which is not the case, especially in dermatomyositis. You will see here in this picture that, in fact, dermatomyositis can be very complicated and complex because of the fact that it can also affect the lungs and cause lung inflammation. And this is one of my patients who actually had rapidly progressive lung involvement. So specifically in MDA5 dermatomyositis, you can get pretty quick lung involvement that can be quite devastating to the disease process and needs to be treated urgently. And that is why a multidisciplinary approach is very important in these rare diseases. Our patients with dermatomyositis, including MDA5, can also, patients who have MDA5-associated dermatomyositis, can also have calcinosis, which are calcium deposits under the skin. We think usually in areas of where there was a lot of muscle inflammation, but it could also be in multiple areas throughout underneath the skin or in the hands or in the elbows and things like this. This is something that we look out for all of our patients in dermatomyositis. But I've been saying MDA5, hoping that this was already discussed at some point, or you have already been learning about it, or have heard about it, but I've put it right smack in the middle here. And this slide is to highlight myositis autoantibodies. And myositis autoantibodies are biomarkers or a blood test that we can check that actually indicate to us if you are positive for this specific blood test that is called MDA5 or specific for MI2, then we know that you have dermatomyositis, most likely. Now, and in addition to that, depending on which antibody you have or autoantibody you have, we get some insights into the prognosis or the extent of organ involvement your disease may have. For example, with MDA5, we know that patients can get lung involvement and particular rashes, versus if someone else has MI2, we know that they're usually not going to get skin involvement. I mean, sorry, it's not going to get lung involvement. And these are some other autoantibodies that are known in dermatomyositis, but I'm not going to be talking about these today in detail because we know that today we're trying to highlight dermatomyositis, specifically MDA5 dermatomyositis. So again, in MDA5 dermatomyositis, one of the blessings of MDA5 dermatomyositis is that I feel that I always teach my fellows and my patients also when I'm examining them in their hands. It's a very classic skin rash that is seen with MDA5 that has been consistently reported throughout the literature. And one of them is these kissing papules, and you can see that these flexor areas of the hands when you're looking at them like this. You can see that these rashes right here at the folds are almost kissing upon each other or kissing papules. And these can be quite painful, but when we have this and see this on exam, we know this is going to be MDA5 dermatomyositis. So in fact, the skin exam can be very important, especially in dermatomyositis, especially in MDA5. And as I said, interstitial lung disease or lung inflammation can occur, and it can occur quite rapidly. And another skin feature, and this is another example, that picture before was a picture of my own patient who had these kissing papules, but you can also get ulcers, which is pretty characteristic of MDA5 dermatomyositis. And it can occur over the knuckles, which can be quite painful and very difficult to treat. So in the past, now we have updated this, but in the past, we have actually looked at our entire cohort at our Johns Hopkins Myositis Center. And we found that in addition to the skin involvement and the muscle involvement, and also the classic skin rashes that I already told you about in MDA5 associated dermatomyositis, we also found that patients can get a lot of inflammation in the joints. So I think this is less appreciated, but we definitely see this where, we're so busy treating the skin and the muscle that we forget to think about if the joints as another organ, so to speak, is involved. And it's important to treat the joint involvement because it can be quite painful for our patients with a lot of joint stiffness as well. And the good news is most of our patients, over 73% actually, who had lung involvement were very responsive to immunosuppression or medications to dampen the immune system so it prevents it from fighting itself and causing more inflammation and more damage in the organs in MDA5 associated dermatomyositis. So this is a schematic of how we approach or how I approach patients who have myositis with lung disease, because I think the primary driver of morbidity in our patients with MDA5 associated dermatomyositis is interstitial lung disease. Because if it's not picked up early, it's not monitored appropriately, then our patients can sometimes actually get progressive disease and scarring, and it can be very, very difficult to manage. And so the approach to dermatomyositis treatment is largely dependent on which organ is active and which organ, is it skin, muscle, lung, or joints, that is driving the treatment tree, basically. And so in this case, if you have lung involvement, the first line medications are these that may sound familiar, like steroids or prednisone, and these mycophenolate or azathioprine. And in refractory cases, we will use tacrolimus. And IVIG is also used in conjunction with these agents if patients are not doing well. And of course, rituximab is another medication we will think about in our patients who have interstitial lung disease. So the overall breakdown or the treatment paradigm of dermatomyositis is similar to the previous one, you can see, except there's no methotrexate for those patients who have interstitial lung disease. But if you have dermatomyositis without lung involvement, you can consider these agents again. And then IVIG is here because we know it works very beautifully for the skin and also the muscle. And also rituximab works, especially in patients who have autoantibodies. And that's another reason why we would use rituximab with these other agents. And more recently, there's been a lot of interest in these newer agents, such as JAK inhibitors, which are on the market right now. There's multiple ones that are available. And currently, there is a phase 3 trial ongoing for dermatomyositis. And in addition, anti-interferon beta is another phase 3 agent that is being treated, in clinical trial right now. So hopefully, we'll hear more about these drugs as well. So the key take-home points today is that MDA5 dermatomyositis, I hope I was able to impart to you that it is a very complex disease, can affect multiple organs. And the good news is that there are multiple oral agents we can use and steroids, but we also have multiple other agents that are in the pipeline. And I forgot to mention IVIG was FDA approved for dermatomyositis, and so can be used to treat MDA5 associated dermatomyositis very effectively. And the key thing is multidisciplinary team approach, because I can as you can see, it could be multiple organs that are involved, and it can be challenging to treat. And that's why all the physicians, the rheumatology, pulmonary, dermatology, needs to really put their heads together for our patients with this rare disease so that we can fight it and treat it and hopefully get it into remission. And thank you for your attention. And I hope you have a wonderful rare disease day. Thank you.